Welcome to WEO's video capsule endoscopy course on the topic of small bowel acute bleeding. Should you have any questions, please use Zoom's Q&A function. Without much further ado, I'm handing over to course core director Jean-Francois Rey.
Good morning, good afternoon, good evening. It's my pleasure on behalf of WEO to chair this webinar with our colleague, Dr. Admar Borges and Dr. Cristina Carretero. Small bowel bleeding had tremendously changed 20 years ago. In early 2000, we simultaneously have two important new tools for small bowel. First, it was a capsule endoscopy developed by Given Imaging and early in Europe and States, and nearly simultaneously, Dr. Yamamoto developed the double balloon in Japan. And with two new tools, everything changed for small bowel exploration and treatment. And it's my pleasure today to be with you and my colleague, and also a pioneer, Hiro Yamamoto, for 1.5 hours to talk and to see what is going on the small acute bleeding. Now we have a short video. This is the last version of Capsule sponsoring this webinar today. And now we have the first speaker.
Could you turn on your camera?
Okay. Okay. So now we have a first speaker. It's Dr. Cristina Carretero from University of Navarra in Spain. And the talk is When Capsule Goes First. Please, Dr. Carretero.
Thank you very much. So, ladies and gentlemen, good morning from Spain. I would like to thank the World Endoscopic Organization for the kind invitation to participate in this course. And my topic today is acute small bowel bleeding when capsule goes first. But before that, let me start from the beginning. A gastrointestinal bleeding with a negative upper and lower endoscopy happens in around 5% of cases. And now, with the appearance of small bowel capsule endoscopy and device-assisted enteroscopy, we know that more than 80% of cases are from the small bowel explored completely. Of course, we have many options. We can use the red blood cell scintigraphy, the CT angiography, capsule endoscopy, device-assisted enteroscopy, arteriography, and even barium studies. And we need to know the differences between them to use them correctly. As you may know, the main difference is the diagnostic yield. As you can see here, the diagnostic yield of capsule endoscopy is around 42% if we compare it to small barium radiography, having a 6% of diagnostic yield in this study. If we compare it to push enteroscopy, again, it's superior. In this study, they showed a 56% of diagnostic yield compared to 26% of push enteroscopy. Compare it with angiography, again, it's superior, 53% compared to 20%. And as you know, we need a bleeding rate of 0.5 milliliters per minute for angiography, but comparing it with the capsule, it's very effective for localization and it allows immediate therapy. If we compare it to CT angiography, again, the capsule has a higher diagnostic yield of 72% compared to 24% of the CTA, but the CTA is widely available and can be performed rapidly. If we use CT enterography instead of CT angiography, again, we see that the capsule has a higher diagnostic yield with more than 60% of diagnostic yield compared to 21% of the CTE. But to note that when we have a negative capsule endoscopy, subsequent CTE revealed a 50% positive diagnostic yield. Conversely, with a negative CT, subsequent capsule endoscopy revealed a 57% positive diagnostic yield. So we can consider these techniques as complementary. And last but not least, comparing capsule with double balloon enteroscopy, the diagnostic yield is very similar, 62% compared to 56% in double balloon enteroscopy, but the capsule endoscopy has a higher rate of complete explorations and it's non-invasive. So putting all this together, it seems that the capsule endoscopy should be the test of choice. But even more, the diagnostic yield may be influenced by the type of bleeding. In this study, Marco Panaccio showed that patients with overt bleeding had a diagnostic yield of more than 92%, compared to a diagnostic yield of 44% in cases with, in patients with occult bleeding. But not only this, patients with ongoing overt bleeding had a higher diagnostic yield, 92%, than patients with previous overt bleeding, with only 13%. But if we focus on this group of patients with previous overt bleeding, we can see that if we perform the capsule within 14 days after the bleeding, the diagnostic yield is around 67%, but it's decreasing if we wait to perform the capsule. If we wait 3 to 4 weeks, then the diagnostic yield decreases to 39%, but if we wait more, 2 to 3 months, then the diagnostic yield is almost 0. And is there room for an urgent capsule endoscopy? While capsule for severe ongoing overt bleeding is very attractive because it's safe, it's easy to use, and it seems feasible. In these two studies, the first one, the yield to detect an active bleeding, not only the source of bleeding, but an active bleeding, decreases as day goes by, being 36 in the first day, 23, almost 24 the second day, and decreasing every day. But even more, this other study analyzed the performance of urgent capsule endoscopy in this setting, and they found that I performed the capsule the first day after the bleeding within 24 hours. The diagnostic yield was almost 90%, 88% in this case, and waiting 1 day more, so from day 2, the diagnostic yield decreases to 33%. But even more, performing these urgent procedures raised the overall detection rate 4 times. So it seems that we need to perform the capsule the sooner the better. Another question that it's often asked is do we need to repeat upper and lower endoscopy before doing the capsule? Well, the answer may be in this study. In this study, they analyzed 317 patients with obstructed GI bleeding. They found lesions in 68% of cases, 215. Almost 30 capsules were negative, and they found lesions outside the small bowel in 3% of cases, lesions that were reachable by upper and lower endoscopy. So for these authors, it seems not to be cost effective to repeat upper and lower endoscopy before doing the capsule. But you know that we can never say never, and we can think about doing a second look endoscopy if we suspect an overlooked lesion, if the initial endoscopist used suboptimal equipment or has less endoscopic experience, or in cases of inadequate mucosal visualization because of poor colonic prep. So my take-home messages are that there's no need to do a second look endoscopy in all patients. Capsule seems to be very good as a first-line procedure in bleeding patients, and we need to do the capsule the sooner the better. Thank you very much for your attention.
Thank you. It was a nice paper, and we will talk about the question later on. So now, the second paper is when enteroscopy goes first. It's from Marianna Arvanitakis from Eras Hospital in Belgium. Please, Marianna.
Well, thank you very much. I'm also very privileged to be a part of this panel on this important subject. So I'm happy to have the second presentation after Cristina's because it's very complementary. And I completely agree on the importance of capsule endoscopy, but in some cases we can go to enteroscopy first. So this is the agenda of my talk for the next 10 minutes. I will show you the workups that are recommended for suspected small bowel bleeding, when to go for enteroscopy first, some deep enteroscopy modalities, and a short video case. So first, it's important to have an overview of what could be the cause of small bowel bleeding, and this will depend also on patients' characteristics, comorbidities, on age, and you see here the most frequent etiologies. So less than 4 years, 40 years of age, we will look mostly at tumors, polyps, Meckel's diverticulum, Dieulafoy lesions, and ulcers, either Crohn's disease, either NSAIDs related, and celiac disease. In patients older than 40 years, angiectasias are the most frequent finding with NSAID related ulcers, non-specific ulcers or erosions. And then we have rare causes that we have to keep in mind as well. But it's important to know that from all these etiologies, there are limited situations where we can really have a therapeutic yield with deep enteroscopy. And the most clinically pertinent ones are angiectasias, Dieulafoy lesions. So these are the two workflows I'll show you. This is the one that's recommended by the American Association. And we see that in case of suspected small bowel bleeding, we will not always repeat, as Cristina said, but in some cases we might go to repeat upper and GI examinations, but we will go to a small bowel evaluation in most of the cases. And in patients who are stable, you will go for video capsule. We also talked about this important element of being as close as possible to the bleeding episode, and of course the diagnostic yield, which is still not perfect, but this is how we're getting, and we're probably going to be even better with the new technologies. In case of an unstable brisk bleeding, a patient that comes to the ER with instability, with overt bleeding, we can go to a CT. We know that this will require there is a threshold of the bleeding rate to have to see the extravasation and to apply therapy with angiography. And in this case, we could go to device-assisted enteroscopy if we have a sign, for example, on CT, but the angio is negative. If we look at the European guidelines, again, we will divide occult to overt. And here we see clearly that the European guidelines and overt bleeding, we can consider a deep device-assisted enteroscopy. And this is the cases where you know that upper and lower GI tracts have been examined, that there's no bleeding there. If you have a CT that shows some suspicion that this could be small bowel bleeding, and if you have a patient that you know who has lesions in the small bowel that have bled and that are at risk for recurrence, and you're on a situation where you want to go immediately to a therapeutic option. But in most cases, as Cristina said, we will go for capsule. You see here also therapeutic indications. When do you go to deep enteroscopy? Of course, you will be guided by small bowel if you have significant findings, but you also can go in cases of suspected small bowel overt bleeding for hemostasis. So which route? This will be also tackled in another lecture, but it's important when you go for in an immediate device-assisted enteroscopy in an emergent setting that we know these ratios that based on previous examinations of capsule endoscopy, of time to from pylorus to lesion and time from pylorus to cecum. If it's more than 0.6, then you will go with, if it's less than 0.6, you will go with anterograde, more than 0.6 retrograde. In this case, in an acute setting, we will go for anterograde approach. Why? Because we know that most of the lesions are proximally setted, because it's we have probably a better progression if you go with anterograde, and also because if you go by retrograde, you have the backlash of the blood coming, and so your visibility is probably more difficult. What about sedation, deep sedation, general anesthesia? In these cases, of course, conscious sedation is not a choice, but between deep sedation and general anesthesia, probably in these cases, we will choose general anesthesia because of the acute setting, the risk of aspiration, and the need to have a good safety profile. So general anesthesia with intubation. So what we can do, this was also nicely illustrated by Jean-Francois, that first we used to push enteroscopy, which was not very efficient. Then we started seeing things with capsule endoscopy, and then we started progressing with device-assisted enteroscopy and the double balloon, which was a landmark invention by Professor Yamamoto. And then we have had all these different devices to achieve a deep enteroscopy. So when we see the small comparative styles, there's no large-scale prospective RCTs, but overall, deep enteroscopy is the double balloon enteroscopy is the deepest, the simple balloon is easiest to perform, and the manual spiral that was initially developed was the quickest. So we have a new kid on the block, which is the motorized spiral, which takes the design of the manual spiral, and it involves a motor which is incorporated in the reusable scope, which is like a pediatric colonoscope with the incorporated motor, and you have a single-use overtube which is connected to it and can provide forward movement or backward movement with a clockwise rotation and respectively anti-clockwise rotation. So this is the data that we have until now with this new device. These are the studies we did with Düsseldorf. First, the first prospective clinical feasibility study with anterograde procedure only, 140 procedures in 132 patients, high technical success with an acceptable diagnostic and therapeutic yield. And we see the important progression depth and the good safety profile. This was confirmed with the second study where we tried to obtain panenteroscopy, so either anterograde plus retrograde. And in this case, we also had good technical success in safety profile, but as well, 2/3 of the patients where we had obtained a total enteroscopy, so examining all the small bowel. This is another study from India showing that it can be applied in a real-world setting in a tertiary care hospital with different type of patients with the same results. And I'll finish with this short video case, which really illustrates sometimes the use of going immediately to device-assisted enteroscopy for bleeding. So this patient, 70 years old, with anticoagulants for permanent atrial fibrillation. She had melena, some bouts of melena with anemia since months, but she presented with severe melena and hypotension with hemoglobin levels of 6. She was in the ER, she was resuscitated, she had gastroscopy that revealed no bleeding, and was taken to CT. On the CT, we saw that there was a suspicion of arterial bleeding in the mid-jejunum, as you see here. She was afterwards immediately taken to interventional radiology with angiography, but the bleeding was not identified. And so she was transferred to undergo antegrade enteroscopy with motorized spiral in our department. And this is the video. So we see that there is a significant bleeding lesion here. And this is consistent with a dual fois lesion. In this case, of course, applying APC is not a choice because we need another hemostatic technique, and the clipping is the technique of choice here. We have the water jet that really helps us clear the working scene, and here we put one clip, but you see that there's still residual bleeding, so we completed the treatment by putting 4 clips in total. You have here a very stable position with the motorized spiral, and you have a 3.2 millimeter operating channel that helps have a good passage for the different devices you want to use. So here we'll put the last clip, and after the hemostasis is finished, we will confirm that there is no residual bleeding, and we will complete the procedure by tattooing the area of interest about 1-2 centimeters upstream the lesion to be able to come back if required. So this patient went very well after this single therapeutic session. So in a nutshell, you can use your diagnostic and therapeutic tools according to the clinical setting. In this case, in some cases, we might need to go to enteroscopy as a first step. It can provide possible diagnosis and treatment in an acute set of overt bleeding. Deep enteroscopy can be performed with many different modalities, but it's still a challenge. Depth and speed are not everything, and we still have to increase our diagnostic and therapeutic yield. And this really depends on the selection of the patients, and motorized spiral is a promising technique for the future. So thank you very much, and we're happy to answer any questions.
Thank you, Marianna. You show very nicely how it's important to stop bleeding, and with a spiral, it's easier because we have a large channel. And one important point, when we have a bleeding patient, you should put as many clips as necessary until you stop the bleeding, and to clean with a water channel in order to see we are really stop the bleeding. It's a very important point. So we will take the question later on, and we move now for the third presentation. It's from my friend Admar Borges from Brazil, and how to choose oral or rectal route. Please, Admar.
Okay, thank you very much. I am very pleased to share this session. And which direction is the best to approach this de la Foix lesion? You see this film is this video that was recorded under the water. So the choice of the right route for enteroscopy provides session efficient and cost-effective treatment. Valdivia and colleagues reviewed this matter. Shall we take the oral or rectal approach to get to the lesion? Device-assisted enteroscopy is a time-consuming procedure. Appropriate insertion route reduces burden on patients and endoscopists. Route selection depends on clinical manifestation, black stool, guide to oral route, bright red stool or dark red stool, guide to rectal route, cross-sectional image, and mainly capsule endoscopy. As an example, capsule endoscopy guide to oral route in this case. It has been recommended for our approach route when previous investigations are unable to provide data about lesion location. For general indications, integrated enteroscopy appears to provide a higher diagnostic and therapeutic yield. In the setting of massive overt GI bleeding, integrated route is preferred. For clinical reasons, it has higher diagnostic yield in the small bowel bleeding. And whereas in rectal route, blood and clots decrease visibility, flowing blood and clots proximally hamper bleeding and proximally hamper bleeding point identification. This aortoenteric fistula, enteroscopy was not needed. It was treated by endovascular radiology. The progress indicator gradually demonstrates the advancement of the capsule. Software are lacking for a more accurate localization of lesions. The anatomic half point of small bowel is usually more proximal than 50% of capsule transit time due to variable speed of capsule in the intestine. You can see different cutoff from 50% to 75%. There is no consensus on this matter. For less than 50%, the frequency of reaching the target lesion by integrated enteroscopy was 94%. For more than 50%, the frequency to get the lesion by rectal approach was 100%. What the endoscopists want the most is suddenly to come to come face to face with the culprit lesion. I will conclude by remarking on the next generation wireless capsule with these localization capabilities. Imaging technology. Thank you very much.
Thank you, Admar. It's a very nice paper. And we take some question later on. Now it's my pleasure to introduce Hiro Yamamoto, as you know, the pioneer of double balloon endoscopy, and he will give a talk about enteroscopy hemostasis, APC, bipolar probe, clip, ligation, hemostatic power, injection, and what else? Please, Hiro.
Thank you. Thank you for a nice, kind introduction, Professor Rey. And I'm honored to be invited to this important panel. Let me share my slides. And this is the, can you see my slide now?
Perfectly, thank you.
Good, okay. The topic I am asked to talk is the enteroscopic hemostasis, APC, bipolar probe, clip, ligation, hemostatic powder injection, what else? And this is my COI, Fujifilm company. And as you heard from the previous speakers, the balloon assisted enteroscopy has double balloon and single balloon, and device assisted enteroscopy means balloon assisted endoscopy and spiral endoscopy. So this deep enteroscopy changed the therapeutic procedures in the small intestine. And I will talk about double balloon endoscopy. Using the double balloon endoscopy, you can insert the endoscope from the oral route and anal route, and almost entire area of the small intestine can be examined. And what kind of therapies can you perform with the deep enteroscope? Hemostasis, polyp strangulation, balloon dilation, and almost any kinds of endoscopic procedures you can perform in colonoscopy can be performed in enteroscopy as well. And I want to focus on endoscopic hemostasis. So APC, bipolar probe, clip ligation, and hemostatic powder injection. But I usually use APC and clip and injection. So this is the classification of the vascular lesions of the small intestine. Type 1 is angioectasia, the red area or spot, but without pulsatile bleeding. Type 2 is a probably a durable lesion, pulsatile bleeding. And type 3 is AV malformation. Anyway, this is an example of type 1B, that is angioectasia. In this kind of capillary lesion, I recommend using APC. And when you use APC, using a transparent hood makes the procedure easier. But sometimes it starts to bleed. In that case, I use injection with epinephrine and stop the bleeding, and apply APC again. So this is the example of APC and injection. And the other one, this is arterial lesion. You have to pay attention to the pulsatile movement. You see the pulsation here. And in this case, APC is not indicated because it can cause massive bleeding. So I think clip placement is better. even with clip, it started to bleed. But using several clips, then I could stop the bleeding completely. And this is the durable lesion. And in this case, you can't see the lesion itself, only a tiny clot. So without bleeding, you can't see the lesion itself. But because of the clot here, I thought this was the bleeding source. Now it started bleeding. So in the water, you can see the pulsatile bleeding. Then clip placement and stop the bleeding. And when you perform therapeutic procedures in the small intestine, you have to know the anatomical features of the small bowel. Small bowel is a long and tortuous tube-like structure and mobile in the abdominal cavity. So you have to stabilize the endoscope before starting the therapeutic procedures. And the lumen is narrow, so working space is limited. You should avoid over-insufflation for stable control, and using a transparent hood at the endoscope tip can make the procedure easier. And CO2 insufflation is recommended rather than air insufflation. And intestinal wall is thin and soft, so it has a high risk of perforation. So consider submucosal injection whenever the risk of perforation is considered. And the timing is important for hemostasis. For ongoing small intestinal bleeding, transoral enteroscopy without bowel preparation is recommended. This is an example. That's because in the small intestine, the blood goes down to the anal side by peristalsis. So the blood is the good indication of the bleeding source. If you perform enteroscopy from oral route without preparation, even without preparation, you don't see any blood until you come close to the bleeding point. And when you come to the bleeding point, then you start to see the blood. So you have to look for the bleeding point near the area where you started to see the blood. And in this case, it was easy to find the bleeding point here, durable lesion. And in underwater, you can see the bleeding point very clearly. And clip placement can be performed. Like this, small intestinal bleeding, from the bleeding point, the blood goes down, and retrograde without preparation, then difficult to keep view and regurgitation of blood. So it becomes difficult to find the bleeding point. Retrograde with preparation, even with preparation, the insertion of the endoscope makes the regurgitation of blood. So you lose the milk mouth, so you can't find the bleeding point easily. And anterograde with preparation, you wash away the blood, so easily miss the bleeding source if the blood has been washed away. So anterograde without preparation is recommended. Bleeding source can be found guided by the bloody intestinal fluid. So what we do is, when you see a blood, then one clip is placed. Then, even if you miss the bleeding point and the blood becomes darker, then 2 clips are placed. Then between 1 clip and 2 clips, look for the bleeding point, and you can find the bleeding source. And what else? What else? I would like to introduce gel immersion endoscopy. This is my junior colleague, Tomonori Yano. He invented the gel immersion endoscopy. This is my my paper in year 2000, colonoscopy in flowing water for lower GI bleeding. If you use water flowing in the colon, then you can find the bleeding point very easily. But have to be flowing. That's because water is mixed with blood easily. So Dr. Yano came up with an idea of using gel instead of water. In the water, blood is mixed with the water. So without flow, it's difficult to maintain a good view. But in the gel, blood is not mixed with the gel. So it is easier to keep clear endoscopic view. It looks like a slow motion video. Even when the bleeding is massive, still in the gel, it's not that massive. So it's easier to find the bleeding point and stop the bleeding. Now, ViscoClear is available from Otsuka company in Japan. Now, this is the commercially available product for endoscopic hemostasis in Japan. And I want to show you some example. This is a recent publication. Low pressure endoscopy using the gel immersion method facilitates endoscopic hemostasis of duodenal diverticular bleeding. This is a rather massive bleeding. And if you insufflate the air, then in this case, it is difficult to find the bleeding point. Not only that, the maneuverability is very poor because of the insufflated stomach. So suck the air and aspirate the air, and it becomes a little bit easier to control the endoscope, but still difficult to secure the view. But using gel, it becomes easier to keep good endoscopic view because the blood is not mixed with the gel easily. But inside the diverticulum, it is difficult to go in. So we placed a bit longer transparent hood. And with the help of this transparent hood, we could see the inside of the diverticulum. And with that gel immersion endoscopy, the bleeding point can be identified. This is the bleeding point. So in the gel, it looks like a small, slow motion, and clip placement was easy as long as a good endoscopic view can be maintained. So this is a conventional method. Using gas, even if you can find the bleeding point, that bleeding point will be covered by the blood easily and suction, but covered again. In the water, you can see the bleeding point clearly, but when the bleeding is massive, then it is mixed with the water and you lose the view. In the gel can maintain, will maintain a clear endoscopic view in front of you, even with rather massive bleeding like this. And double balloon endoscopy is suitable for this method because the endoscope balloon block the backflow. So the gel is placed right in front of the endoscope like this. So you can make a clear endoscopic view with the gel placed in front of the endoscope. So these are the conclusions. Enteroscopic hemostasis is feasible, similar to colonoscopic hemostasis. However, it should be performed carefully, considering potential risks. And use food and CO2 to avoid overinsufflation. And select appropriate route for hemostasis in the small intestine. And the timing of the procedure is important for successful identification of bleeding source and hemostasis. And gel immersion endoscopy is useful for hemostasis in the small intestine as well. Thank you for your attention.
Thank you, Professor Yamamoto. It was very nice to see this new development, and probably we'll have a lot of questions later on. Now it's the time for my presentation. Can you see my presentation?
Yep, perfectly.
Okay,
Thank you.
perfect. It's worked well. So I will talk about a new concept, capsule for non-hematemesis and upper and medium bleeding. You know, the major indication for capsule in clinical practice, it's obscure GI bleeding, which is a major indication as we saw today. We have also Crohn's disease, suspect or monitoring, and of course, small bowel tumor. But you know, small bowel tumor difficult to diagnose. In most of the cases, it's easy when it's obscure bleeding. And I talk today with a new indication, non-hematemesis upper and my bleeding. So we need to have a new type of capsule, and it's a magnetic guided capsule, present and future. We were lucky to do the first clinical trial in my hospital 10 years ago with Olympus and Siemens equipment. Then we have an Ancon capsule, well developed in China. And more recently, Jinsen developed robot and magnetic guided capsule shown in the Capsule Summit in 2019. So the first clinical trial was performed in my unit with 3 Japanese colleagues from Keio University, Showa University, and Jaiki University. And the goal of this magnetic guided capsule was a kind of low-level MR. The patient had to drink some water in order to have the capsule move in the stomach. And we have, of course, joystick and to manipulate the capsule. So the capsule could dive on the lower part of the stomach and could be up on the air-water surface. And we have a possibility to maneuver with joystick the capsule rotation, tilting, and put the capsule jumping if the capsule was trapped in 2 gastric fold. So what is the first trial that we did? We did with a patient position in 3 position, usually lateral side, and then we move supine, and then we move left. And what is interesting with the 3 position, we are able to look very carefully 90% of the stomach and combine to gastroscopy. So this equipment was not commercially available because the MR was a large machine, but for the clinical trial we did later on with 3 universities and some colleagues from Europe, it was quite successful compared to the conventional gastroscopy. And then the same idea came from China with Ancon, published in 2016, the interest of the Ancon system, it's a small magnetic field in a small equipment. And by the time being, there are more 200 hospitals using this equipment in China, because in China, the number of gastroenterologists is quite limited with a huge population, and you could use now this magnetic gastric capsule in order to make a screening, also to diagnose and to avoid the use of conventional gastroscopy. That is not the same, of course, outside China. But the equipment are very, very effective, and they get the same result that we have in Saint-Laurent-du-Var. And the last version is coming from Omom. It's exactly the same that we use for the Ancon. So you see a small table and you have a joystick, but instead of the joystick and manual screening of the stomach, they use the robot. And that means, in that case, all the examination is carried on by robot with AI. So we have nothing to do except to see the overall result. And this is the first paper published in China and just issued in Lancet Gastrology this month, 140 cases, and they compare the robot capsule with a conventional Olympus endoscope. As you see, the picture are quite amazing. The preps in this case is quite simple because the patient is fasting and you have to drink some water for 1 hour before the examination, and the robot screen all the stomach. As we did in Saint-Laurent-du-Var, we show that the concordance between a conventional endoscopy and a capsule, gastric magnetic capsule, are very, very high. And you see, we have exactly the same. We could see gastritis, we could see small polyp, we could see submucosal proton and mucosal erosion. And what is interesting, when we compare the conventional endoscopy and the magnetic guided endoscopy, in some case, the capsule are missing some lesion. In some cases, the endoscopies also are missing some small lesion because the capsule is very close to the mucosa and they could detect some lesion not seen of the capsule. But the overall results are very similar. And the capsule, what is interesting, this kind of gastric capsule then could be released in the small bowel. So with the same device, we could perform a gastric examination and then small bowel examination. Of course, the small bowel transit time is exactly like we given imaging the Olympus capsule as we did for 20 years. And so with this equipment, we come back about, Dr. Shink and Dr. Cave timing of video capsule endoscopy relative to the over-obscure bleeding, as did already show Dr. Carretero. If we compare the inpatient and the outpatient in two groups, a capsule performed within 3 days, a capsule performed after 3 days. The overall diagnosis is much higher when we do a capsule earlier, not only for the diagnosis, but also for the procedure. And the hospital stay is shorter. So is the first message we heard today from Dr. Carretero. We have to do the capsule as soon as possible when we have suspect bleeding. And then we have a paper published 2 years ago by the same group, my friend David Cave. They make a randomized control trial comparing efficacy of early video capsule and with a standard cap. Again, it was in that case the conventional capsule, and you see the patient is done as soon as the admission for melena, hematochezia, or severe anemia versus standard care. And again, we have two group of patients, and the bleeding source was diagnosed in C4 36.3% in early capsule and only 31.9% in the standard group. So it's why now we develop this new concept with a guided capsule. So in a non-hematemesis bleeding patient, we perform the capsule in emergency before gastroscopy, before colonoscopy, and in intensive care unit. And so we use the gastric capsule to examine the stomach, and then we release the capsule to a small bowel prior gastroscopy. And we will show a poster in the European week next week on web and virtual. And we already performed 41 examinations with a Ancon system in Saint-Laurent-du-Var for a next trial. So in conclusion, capsule endoscopy is a breakthrough in small bowel endoscopy for the last 20 years. And the double balloon also was important for not only diagnosis, but treatment, because, you know, when we do capsule endoscopy, you need to have a double balloon or single balloon with spiral equipment. The magnetic guided capsule is the next step, manual robot, and the emergency capsule for non-hematemesis overbleeding patients could be a new possibility for patient management. And if you came a little bit late on this webinar, I remind you, we will look forward to see you next year in Kyoto for the World Congress of Digestive Endoscopy and also the Congress with GGS. Thank you for your attention. Mr. Chairman, ladies and gentlemen. No, it was a pleasure. Okay. So now we have a time for questions. Do we have a question for the panel? If not, I will start with a first question to Hiro Yamamoto. You show very nicely while you are using the hook. The hood is not affecting the progress of a small bowel. You could make effective the double balloon with a hook without any difficulty, even if you have a fragile mucosa?
Yeah, actually, using a transparent hood, it becomes easier most of the cases, because you can find the next lumen easily. So just hook the fold and just try to shorten the small intestine to the enteroscope. In that way, you don't have to push very hard, just jiggling, and straight away the endoscope can be inserted. So I think and it is easy to manipulate the endoscope with the transparent hood. But in a very limited cases, very tight angulation with adhesion, maybe the hard part becomes a little bit longer, so it could become difficult, but very limited cases.
Thank you. I have a question both to Hiro Yamamoto and Marianna Arvanitakis. You know, in bleeding patient, it's most of the time difficult to find really the bleeding source. Are you aside of water jet, aside of the gel, what is very interesting, have you tried the new equipment for Olympus or for Fuji when we RDI? You know, you have a filter. I know personally the Olympus because I'm working, like Yamamoto is working with a Fuji, I work with Olympus. So with the RDI on the last Olympus equipment, with RDI, we have a filter in order to isolate the bleeding source. Are you using this equipment or the same kind of equipment in your equipment? Marianna, please.
No, we don't use for the time any electronic identification of bleeding. But I think that Professor Yamamoto very nicely illustrated practical tips and tricks of how to really find the bleeding point by physical components of the flow of blood and the isolation of the segment of interest, and of course the use of gel, water, or even gel instead of air. But it's at the cap, of course. But it takes sometimes patience and being very systematic and looking around in all the parts of that you examine. So you examine thoroughly the walls of the small bowel. So it's still based on let's say physical components and not electronic or digital chromo.
Because personally, I use the spiral equipment with the RDI. We last, and in some cases, it's quite useful. Yeah. It's amazing, you know, to use, and of course to see where to put the clip when you have a lot of clot. The RDI is nice because it could differentiate clot, fresh clot, from fresh blood bleeding.
Yes, I agree. I agree. I have an experience of using RDI in the ESD. When I perform ESD in a live demonstration course, and the only endoscope I could use was Olympus, so I used RDI, but it was very good actually. When the bleeding happens, then turn to the RDI, and the blood, the pool of the blood becomes just orange. Yeah. Only the bleeding point remain to be red. Yeah. So in the pool of the blood, bleeding point can be seen. So it's very nice. So I agree. It can be used in the small intestine as well, I think.
Yeah, I think so. Do we have any questions from the colleague? Please. So, Admar, I will ask a question about, you know, the location, which route we should go. What do you think artificial intelligence will be able to give a more accurate than the small bowel progress indicator of the 3D equipment?
Yes, that's what we hope. Is the artificial intelligence help us in the near future? Because at the nowadays it's a little inaccurate. So we can approach by oral, and sometimes we have to approach by rectal route. And when we are with an urgent case, it's difficult to prepare the colon and to do the both approach it the same day. So I hope that in the near future the artificial intelligence can help us and can give us some instrument as the artificial intelligence. It is beginning in upper and lower endoscopy, but in the later on, we hope that we will get into a small bowel endoscopy as well.
Thank you. Please.
Yeah, I agree with Admar, because now with the PILCAM crowns, for example, the localization depends not on the timing, but on the distance of the capsule. So I hope in the near future, we will have better tools for localization as well.
Thank you. You have to know, and I talk for the audience, there are two Chinese companies, they work very hard on AI. First is the Hong Kong company. The Hong Kong company with the colleague from China, they published in Gastroenterology 2019 a very large trial, more than 5,000 patients in 20 Chinese universities, able to diagnose very accurately the small bowel abnormality, because most of the AI paper, they talk about bleeding or they talk about, inflammation. But this paper in gastroenterology, they diagnose very accurately all these small bowel lesions. And I think with this kind of equipment not yet available, commercially available, we could make, more accurately where the lesion is located. And the second is from Omum. Omum just published for small bowel. I'm not talking about the robot, but the commercially available Omum equipment. Now they have a smart funding, and the smart funding make also the diagnosis accurately of a small bowel lesion. And I think, it will give us more idea where we have to start for the enteroscopy, for the oral or the anal route.
We have a couple of interesting questions from the audience.
Please.
Not really. And the first question, let's say, about the MRE in obscure bleeding before capsule and before enteroscopy. I think it depends on how urgent is the case. In MRE shows better, they can show tumor, diverticular, blood in the lumen, but most of vascular lesions are flat, so out of reach of MRE. Could you take over, please, John? The second one is to Professor Yamamoto. Professor Yamamoto, may I ask, if you don't have a viscoclear, what can we use to mix our own gel for visualization of bleeding point? Thank you.
Okay, before viscoclear was available in Japan, we were using OS1 jelly, that is for the dehydration patients. Hydration jelly product that is clear, a little bit viscous, easy to swallow. Is that kind of product available in Europe or other Latin America or other countries? I don't know about that. If that is not available, then my friend, you tried mixing the KY jelly and with water and make a little bit viscous solution. And he said it worked. Okay.
Yes, thank you. Thank you. Other question, Borges?
Yeah, yes, just let's go on. Time proceed, the friend talk. What is my question? Thanks for an excellent talk. What is your average time procedure?
For what?
This to Marianna, please. Could you please answer this question?
About your spiral.
Yeah, so for the spiral, we had good timing. Most of the procedures were we could have a good progression. As I said, was 4 meters. Of course, these are subjective estimates, and we should not forget that. But we could obtain that in between 45 minutes. And this was good timing. It gets better with experience, of course. For bleeding, it's of course depends on where the lesion is and how you can identify it. But in the beginning, when we start training in these techniques, I think that you have to have, in elective cases, of course, you have to really to schedule a sufficient amount of time to really take the time to do the procedure correctly. But with experience and the learning curve, you can become very, very time efficient.
Yes, I think, with a spiral, the difficult part is really to get through the chest angulation. And,
yes,
I was lucky 10 years ago. I used the manual spiral. And in my unit, our Pantai daughter, she spent 1 year, so she explained a small trick. And really, as soon as we get through the duodenal-jejunal junction, it's very fast. But sometimes it's a little bit tricky. We have to go in and out in order to get through this angulation.
Yes, and the esophagus is always a bit.
The esophagus. We are like the anesthesiologists. If you have a patient with a short neck, and it's difficult to intubate. Yeah. We have to learn from the anesthesiologist.
Yes, exactly.
Marianna.
I think Cristina has a question from the audience.
Please.
Yes, there are two very similar questions. One is capsule in practical use now for acute possible small bowel bleeding with negative upper and lower endoscopy? And then we have another, which is almost the same, when we should consider small bowel capsule endoscopy in the setup of acute GI bleeding. I don't know if any of you would like to answer, otherwise I can answer. Well,
please.
It's in the guidelines. So for acute small bowel bleeding, we can do upper and lower endoscopy and then do the capsule. And we try to do it as soon as possible within 14 days after the bleeding. But if you could do it the next day or even in the 3 days after the bleeding, it would be even better. As Marianna said, there are also settings where we can use directly device-assisted enteroscopy. In fact, for overt massive bleeding, if you don't have access to the capsule, or if you know that the patient has already angiectasias, you can go directly to device-assisted enteroscopy.
Okay. I think now it's time to move to the two clinical cases. We have first clinical cases, decision-making in acute small bowel bleeding from Dr. Carolina Olano from Uruguay. Please.
Thank you very much, Dr. Rey. I will share my presentation. Can you see my presentation?
Yes, it seems you're at the end of your slideshow already.
It is, sorry.
Start again. It seems you're at the end of your slideshow.
I'm sorry. Can you see this presentation?
No, not yet. Maybe just close it again and restart.
No?
No, not yet.
No?
Unfortunately not. How about I share yours?
Oh, no, it's okay. I will try again.
Okay.
No?
Perfectly. Now, if you just go on full screen, you're all set.
Yeah. Okay, now?
Wonderful.
Okay. Well, first of all, I would like to thank the WEO for this invitation and Dr. Begonia Gonzalez Suarez that shared with me this interesting case. I will present a real-life patient and procedure, a typical example where there is not enough evidence telling you how to proceed, and the decision-making is based on your personal experience and the technical difficulty. This is a 62-year-old male that 7 years ago had presented with anemia and melena. After negative upper endoscopy and colonoscopy, deep enteroscopy showed multiple angioectasia in the jejunum that were treated with APC at the time. At present, he presented with melena. He was hemodynamically stable with a moderate anemia. After, again, negative upper endoscopy and colonoscopy, and because of his personal history, new vascular lesions were suspected in the small bowel, so an antegrade single balloon enteroscopy was performed. When the scope reached the mid-jejunum, an active bleeding was identified. An intense flushing revealed a Yamamoto type 1B vascular lesion. However, it was difficult to tell whether the bleeding was coming from the angioectasia or from a small traumatic laceration nearby. So, and because there is still not a consensus on the best endoscopic treatment for small bowel angioectasia, an endoclip was placed. Notice how difficult a procedure can get in the small bowel because of its peristaltic movement and because of a technical issue that is the position of the working channel. As you can see, the working channel is on the left in this case, so the accessory heads tangentially to the intestinal wall. To overcome this, you can use a cap, a transparent hood, as Dr. Yamamoto suggested, or try to stay as close to the lesion as possible, as in this case. Hemostatic clips have been used in the management of patients with gastric and colonic angiodysplasias. Dr. Jovanovic and colleagues use endoclips to obliterate the feeding vessel for multiple angiodysplasias in the cecum while applying APC, thus encountering less bleeding complications. During APC, you don't want to apply any current to the endoclip, as this could, of course, result on a perforation. In this case, placing two endoclips allowed to expose the angioectasia to APC treatment. It also produced local ischemia, preventing post-APC bleeding. A recent multicentric American study failed to find any differences between hemoclips and APC in terms of preventing rebleeding secondary to GI angioectasia. Thank you very much for your attention.
Thank you. Now we have a second clinical cases from Dr. Ekaterina Ivanova from Russia. Ekaterina is a very old friend of mine for many years. Please.
Thank you, Dr. Rey. Dear Chairman, dear participants of this very relevant and important course, thank you very much for the organizers for the opportunity to speak at this event. And I have two video cases, and the first one is a young male with hematemesis who was diagnosed with gastric lymphoma a month and a half ago. CT/US laparoscopy showed the presence of multiple metastases. That was diffuse B-cell lymphoma grade 4B. The first course of chemotherapy was complicated by obscure overt bleeding, and capsule endoscopy was the first step of intestinal examination, and actually we received just two abnormal images, and the presence of red blood on one of them was so much indication for us to conduct an enteroscopy. So here is a lymphoma of the stomach, and let's look at the second large circular tumor that was found 2 meters distal to the ligament of Treitz. A large thrombosed vessel was also detected, which we prophylactically coagulated with argon plasma coagulation. So this is prototype of therapeutic enteroscope with big channel. that time we had the opportunity to try it. So let's move on. So immunohistochemistry showed us diffuse large B-cell lymphoma with high proliferative activity, and oncologist prescribed epoch therapy for 6 cycles without any other complications. And the next case, the 37-year-old woman with chronic anemia for 10 years and current episodes of melena, that was a reason for admission to the hospital. So you see very low hemoglobin level, and the capsule endoscopy was examination of small bowel, and we have found bulging in the upper segment of jejunum, and of course suspicion on tumor of jejunum. So here is enteroscopy. And on enteroscopy, tumor was detected 45 centimeters from the ligament of Treitz. That time, we were studying the value of endosonography for the tumors of small intestine. And when filling the intestinal lumen with water, you will see it now. So here is the apex of the tumor, and you see filling with water, and intestinal bleeding started spontaneously. We didn't undertake any hemostasis because the bleeding also stopped spontaneously. You see the surface of this tumor without any ulceration or big vessels. So the next angio-CT showed blood supplies to the tumor from the superior mesenteric artery, and in a couple of days, urgent surgery was performed. Large tumor with an intra and extra organ growth with the calcinate site was removed. That was GIST. Let me conclude. Capsule endoscopy and enteroscopy is the main methods for diagnosing tumors of the small intestine. Tumors of the small intestine are diagnosed over a long time, especially for in young patients, and actually usually surgery is the main treatment for tumors complicated with bleeding. But in case of lymphoma, endoscopy is optimal for treatment for hemostasis, since the general treatment is chemotherapy. Thank you very much for your attention, and save the date for end of 2022.
Thank you, Ekaterina. Now we have the time for a couple of questions from the panel, from the audience. Admar, have you looked about if you have some more questions from the audience?
Yes, sure. We have one more question, and what is I would say what is this question is to Dr. Yamamoto. What is the relative viscosity of viscoclear? Please,
Okay.
Dr. Yamamoto.
Okay, thank you for the question. Viscoclear is not that viscous, a little bit viscous. That is a viscosity which you can suck easily through a straw, like you can drink with the straw. Not that viscous. Difficult to describe the viscosity.
And
Okay.
this
Good enough.
can be to it can be to Cristina, please. And do you routinely give buscopa, iosine, during the enteroscopy for better yield?
And not usually, just in some specific cases when I have some troubles, but not in general. I don't know if Marianna uses frequently.
No, we don't use it either. But with device assisted, we have with the balloon, the double balloon, you can really help by using your double balloon to let go the folds, to have a better visualization when you come back. And with the spiral as well, by doing backward movements, you progressively unfold the small bowel to really examine the whole of the mucosa. But we don't use Buscopan because afterwards they have post-procedural pain and they can't eliminate it, the CO2. So I prefer not to give it unless you have really lots of movements at the time that you're doing your therapeutic procedure, but not systematically.
I have a couple of questions from the audience about the capsule. One question: what is the best capsule on the market? I may answer the best capsule on the market will be the next time, because every years the manufacturer improve the capsule equipment. What is especially by the time being important, they improve the sensor. So we have the capsule are much higher resolution, whatever the manufacturer. And most important, they get now the software more effective, and probably with the AI, it will be much easier to diagnose and to diagnose faster with the AI included in the software. And the cost for the guided capsule, the cost is quite high because the station costs about 250,000 USD, and the capsule is also costly. But it's why it's well developed in China. Because in China, due to the lack of gastroenterologists, they have a huge population to screen, and it's why they could use this guided gastric capsule. Outside China, we start to make some clinical trial, but of course, due to the low cost of commercial endoscopy, we are not in the same situation than in China. So I think it's time to close this webinar. Admar, do you have any closing remarks? Or Dr. Cristina Carretero, do you make any closing remarks?
Yes, I would like to thank the speakers for the kindness to take part in the audience, for their attention. Thank you.
Okay, and I will thanks Alexandra, WEO Secretary, for excellent handling. So thanks to all, and see you in Kyoto, and see you in the next webinar organized by WEO. Thank you all.
Yeah.